Today we are speaking about combined oral contraceptive, COCs. Composition formed from estrogen and progesterone. The estrogen component mainly is estradiol, which is 20 times more active than natural estrogen. Rarely we may use mistranol. Recently, low dose pill dose less than 50 microgram. Progestogen, a lot of progestogen used, either nortestosterone derivative or 17 alpha spironolactone derivatives, recent progestogen, as drospirenone, which has anti-androgenic effect. Traditional like levonorgestrel or gestudine or desogestrel or norgestimate. Main mechanism of action through inhibition of ovulation, through negative feedback working upon hypothalamo-pituitary ovarian axis, so it prevents release of FSH and LH. Another mechanism or adjuvant mechanism in form of thickening of cervical mucus to prevent sperm entry, but main mechanism we should concentrate is to suppress ovulation. There is theory it may also work through slowing tubal motility. Efficacy, it's highly effective if used correctly without forgetting any pills. Effect near 100%, more than 99% in preventing pregnancy. However, in typical use, failure rate is 3 to 8% due to missed pill or occurring of diarrhea and vomiting or disturbance of intake, patient incompliance of the pills. This is the main disadvantage of this methods. Types, there is mainly 3 types: monophasic, that those fixed through the cycle, like microcep, genera, Cialis, Narvilon, or biphasic, estrogen fixed, but progesterone dose in the first half of the cycle, the fixed dose then increase to double in the second half of the cycle. Triphasic, change triple here, first 6 days, the dose of progesterone 50 microgram levonorgestrel, then increased to 75 in next 5 days, and then increased to 125 in the last 10 days. Estrogen nearly similar, 30, 40, and 30 microgram ethinyl estradiol. Types of COCs: first generation, when ethinyl estradiol more than 50 microgram, it's now obsolete, no use for it. High dose of estrogen with a lot of complications. Second, dose of ethinyl estradiol less than 50 microgram, any progestin except gestudine, desogestrel, norgestimate, mainly levonorgestrel and drospirenone. Third generation اللي هو progestogen, new progestogen اللي هو gestudine and desogestrel and norgestimate was enter with the same dose of ethinyl estradiol less than 50 microgram. The fourth generation اللي هو more recent اللي هو using spironolactone derivative اللي هو drospirenone, which has anti-androgenic effect. The picture of the different type of COCs, how and when to use. Start in first 5 days of the cycle, regularly every day, 20 days on and 7 days off to allow menses to come. Missed pill, if one pill, there is no problem, take the missed pill immediately if the patient knows has missed pill. 2 pill or more, take the pills also, but we should use backup methods like condom. Emergency contraceptive should be used if sexual intercourse was occurred in preceding 7 days. What's the advantage of COCs? Sure, it's highly effective and has a many benefit of rapid return of fertility, unlike injectable Oteoprovera. So it is suitable for newly married. Completely controlled by the woman. The woman don't need to go to healthcare unit to stop this methods like IUD and implant. Not interfere with sexual intercourse like condom or diaphragm. What is the non-contraceptive benefit of COCs? There is a lot of non-contraceptive benefit of COCs. The first to regulate cycle in patients with irregular cycle. It helps in prevention and treatment of iron deficiency anemia in patients with neuralgia. Decrease the risk of epithelial ovarian tumor because it's inhibits ovulation. Increase incidence of functional ovarian cyst, but not used in treatment. It increase incidence. Decrease the risk of ectopic because it prevent both intrauterine and ectopic pregnancy, unlike IUD, which prevent only intrauterine pregnancy and doesn't prevent ectopic pregnancy. Decrease risk of developing BID because it changes cervical mucus. So transfer of organism is very difficult. Decrease the risk of the endometrial cancer. Decrease, especially in patients with hyperestrogenic state, and there is unopposed estrogenic stimulation, is high risk for endometrial cancer. So COCs gives them progesterone, which help to protect the endometrium. Decrease spasmodic dysmenorrhea and premenstrual tension syndrome because it inhibits ovulation. One of theory of them is occurrence of ovulation. Decrease the risk of benign breast lesion. May protect from colorectal cancer. Decrease the incidence of fibroid. Improvement is very important. Rheumatoid arthritis. It was noticed that during pregnancy, rheumatoid arthritis usually improved. So using COCs is beneficial in this group of the patient. Also, we can use it in treatment of functional intermittent eating, endometriosis, premenstrual tension syndrome, the same benefits, but not preventive, but used in treatment, spasmodic dysmenorrhea, postponing menses for social or religious cause, treatment of hirsutism, but the only this اللي هو continuing drospirenol like yasmin. What is the disadvantage? The need of delays. It's the biggest disadvantage. Injectable and IUD single. IUD and Planon or sterilization single decision, and patient didn't want to every day need pills, and may forget the pills. GIT, it affects GIT in form of nausea and vomiting, especially in patients with gastritis, increase incidence of gallbladder stone or disease. Women with active hepatitis will have deterioration in liver function. It affects CNS in form of increased headache and migraine and depression and liability due to progesterone aspect. The main disadvantage also, it's not suitable with breastfeeding. There's a lot of women during the breastfeeding period, it's not suitable to give them estrogen because it inhibits the breast milk and decrease breast milk. So we use the BOP or progesterone only pills. It may make mild breast tenderness. Genital tract, minimal effect in form of cervical erosion and increased vaginal candidiasis. Cardiovascular system, sure, it increases the risk of venous thromboembolism and myocardial infarction. Metabolic, it increase body weight, but to less extent than Depo-Provera or injectable, 3-monthly injectable. And diabetic patient may lead to hyperglycemia, increased vascular complication, and affect the lipid system, increase cholesterol, triglyceride, and low density lipoprotein. What is absolute contraindication? This group of patients absolutely should not given COCs. Less than 6 months postpartum breastfeeding. Smoker over age of 35, especially if they used more than 15 cigarettes per day. Hypertension, especially severe type systolic more than 160 and diastolic more than 100. Current or past history of venous thromboembolism, ischemic heart disease, so it's rare in reproductive period. History of cerebrovascular accident, complicated valvular disease, migraine headache. It's very important. There's a lot of the women's complain of migraine headache they should not prescribe COCs. Breast cancer, current diabetes, retinopathy, complicated retinopathy, nephropathy, neuropathy, severe cirrhosis or liver tumor, even benign tumor. Relative smoker, less than 15 cigarettes, more than 35 age, mild hypertension, mild cirrhosis, history of combined COCs related to cholestasis. It's not very important like absolute contraindication. Thanks.